Assalamu alaikum. Today we're going to talk about the etiologies, classification, and diagnosis in psychiatry. This is an introductory lecture to psychiatry. We're going to have a general overview of etiologies, classification system of psychiatry, and brief overview of some terminology. And the etiologies in psychiatry is multifactorial. We use the biopsychosocial model to have a better understanding of this etiologies. Not a single etiology can lead to psychiatric disorder. It's usually we have some biological, psychological, and social factors. And here we have the biopsychosocial model. So biological factors could be genetic, endocrinology, biochemical, pharmacological, which all lead to this psychiatric disorder, as well as psychological, such as thinking distortion, emotional dysregulation, also social, such as family factors and life events. Also, we have another model, which is called the 4P model, which have a precipitating, predisposing, and protective and perpetuating factors. So precipitating factor is an immediate trigger such as trauma, stress. Predisposing is long-term risk factor such as genetic early trauma. Perpetuating is a factor that maintains the illness such as lack of treatment. And protective is a protective factor in the contrast of the previous three factors. So here we have the 4P factor with the biopsychosocial approach. For example, for predisposing factor, biological we have genetics, psychological we have attachment style, it comes in early age, social we have domestic violence, poverty, adversity, unstable home life, and divorce. Precipitating such as poor sleep and biological, recent loss, stress, and psychological, school stressor, and social. Protective factors such as adequate diet, sleep, good genes, behavioral strategies, community and family and face support. So what's the point of these two models? These two models give us holistic view of the patient and enable us to focus on each approach and tackle each issue by itself, which gives us holistic view, also improve the treatment. So for example, we'll have a case, a patient with psychiatric disorder, Umar, 26 years old. I feel like people are watching me and I cannot trust anyone. For history of presenting illness, symptoms began 1 year ago with increased social withdrawal, report auditory hallucination, believes his neighbor are spying, stopped working, stayed in the room, neglecting hygiene and not eating properly. So family history, his uncle has schizophrenia. So the likely diagnosis schizophrenia, paranoid type. So we're gonna use this patient in the biopsychosocial model as well as the 4P model. So in the biopsychosocial model, we have the biological factor, family history of the schizophrenia, possible dopamine dysregulation, which gives us rise to positive symptoms, we're going to talk about later on. Psychological factors, we have cognitive distortion, such as misinterpreting harmless action as a threat. In social factors, we have social isolation, lack of support system, possible stressor, and so on. So for the 4P model, we have predisposing factors such as genetic risk. His uncle has schizophrenia, social difficulties. He had mild paranoia before full-blown psychosis. We have triggering events such as a recent stressor, first psychotic episode. Maintaining the disease, we have ongoing hallucination and delusion, social withdrawal, lack of treatment adherence. All of these factors are maintaining the illness to the patient and not improving. For protective factor, there is no substance abuse, so this is a good factor. Potential family support, early diagnosis and treatment. So we have now managed plan based on this model for biological approach, psychological approach, and social approach. So in the biological approach, we're gonna prescribe antipsychotic. Psychological, we have CBT. In social approach, we have encourage social engagement, group therapy, family support, and so on. So here we use these models to have a management plan of the patient. Moving on to the definition of mental disorder. Mental disorders are a syndrome causing clinically significant disturbance in cognition, emotion, or behavior. Reflects psychologically, biologically, or developmental dysfunction, which leads to distress or impairment in daily life. This is very important. There is impairment in daily life. For the classification system of mental disorder, we have two classification systems, ICD, DSM. So ICD is used to classify most of the illness, covers all disease. Chapter 5 will focus primarily on psychiatry, like it covers usually all the disease. Free and widely accessible, used globally. However, DSM or DSM-5 focus solely on psychiatric disorder and more detailed diagnostic criteria. So our focus, a psychiatry course, will be on DSM-5 because it focuses mainly on psychiatric disorder. So here, a comparison between the two classification systems. So in DSM-5, there is a general classification of mental disorder. It's approximately 90 classification. We have neurodevelopmental, schizophrenia, bipolar, depressive disorder, anxiety, obsessive-compulsive, trauma and stressor, dissociative, somatic symptoms, feeding and eating disorder, sleep-wake disorder, sexual dysfunction, gender dysphoria, disruptive impulsive control and conduct disorder, substance-related and addictive disorder, neurocognitive disorder, personality disorder, paraphilic disorder, and other mental disorders. So this is overwhelming in first class, لكن احنا راح نتكلم عن كل disorder deeply in the upcoming lectures. So this is the general classification of DSM-5. For example, in neurodevelopmental, we have autism, ADHD, Tourette syndrome, schizophrenia, we have schizophrenia, delusion, brief psychotic disorder. Depressive, we have a major depressive disorder, disruptive mood dysregulation disorder, and so on. So each general classification has some disorder underneath it. We're gonna talk about each of these general classification in the upcoming lecture. So now we're going to talk about neurosis and psychosis. What's the difference between the terminology neurosis and psychosis? So before I talk about it, let's have an example of neurosis, such as anxiety disorder, and psychosis, such as schizophrenia. Patients with anxiety disorder usually have intact insight and reality testing. What does that mean? The patient will come to you and says, okay, doctor, I know I have excessive worrying, it's disabling me, and I don't know what to do. They have a good judgment of their disease, and also they have intact insight. They know what they're doing. There is no hallucination, there is no delusion, and no negative symptoms. So there is no psychotic feature. We have anxiety disorder, OCD, all of these are called neurosis. Psychosis, on the other hand, patient doesn't have good judgment. They have impaired insight, reality testing. They have hallucination, delusion, and negative symptoms such as schizophrenia. The patient believes that some people spying on them, and they believe this is a reality. They don't understand this is a delusion or hallucination. So this is very important. So what's the difference between primary and secondary psychiatric disorder? Primary is in primary. There is no underlying secondary cause. However, a secondary cause is usually due to medical condition or substance use. So in primary, it is multifactorial, as we explained using the biopsychosocial model. However, in secondary, there is medical condition or substance use that give rise to this psychiatrist illness, such as depression secondary to SLE, psychosis due to substance abuse, and so on. So how can you differentiate between primary and secondary psychiatric disorder? In primary, there is auditory hallucination. It's usually young onset, soft neurological sign. However, in secondary, there is no non-auditory hallucination. It's usually visual hallucination. There is hard neurological signs. It's usually old patient. There is vital signs abnormalities, which is very, very important to know because it gives a suspicion to secondary neurological psychiatric disorder. Previously, we talked about schizophrenia and the difference. We mentioned positive or negative symptoms. So what is positive symptoms? Positive symptom is an excess or distortion of normal function, whereas a negative symptom is a loss or reduction of normal function. For example, positive symptoms, we have hallucination, delusions, disorganized behavior, mood disturbances, and so on. Whereas negative symptoms, we have poverty of thought, speech, lack of ambition, interest, initiation, restricted affect, and poor self-care and hygiene. What's the significance of this positive and negative symptoms? So positive symptoms and negative symptoms give us indication of the prognosis of the disease, of prognosis of the psychosis, diagnosis, and so on. Also, there is a different treatment for each symptoms. Usually, negative symptoms are harder to pick on and harder to treat and have usually poor prognosis, whereas positive symptoms usually are episodic, easy to treat, and have a better prognosis. So it's very vital to know the difference between these two, to pick on the negative symptoms early on to have an early diagnosis of the illness. That's it. Thank you so much.